Denial of food in pregnancy. My mother never allows me to eat anything in the house. When I was pregnant, I used to eat every alternate day. I only had food when my husband gave me money, and that only occurred once in 2 or 3 days. I never ate anything at my house. He, my infant son, is about 2 kilograms in weight. That's approximately 4 pounds. That's the reason the doctor referred me to Sion Hospital. Those ones are like, you know, the women aren't gaining the weight in pregnancy. Let me see if I have one on that. I don't have it in the quote. We actually looked to see if it predicted the amount of weight gain in pregnancy, and we saw a direct tie. Physical abuse. My in-laws treated me very badly during my pregnancy. They always hurt me, and when I became pregnant, they treated me more inhumanely. They thought, now there's the increase of one more person in the family, and automatically expenses will increase as well. They could not afford it. So these were the pregnancy ones. Around delivery, we saw some other issues. This is prevented from going to the natal home for delivery and recovery. I came to my parents' place for delivery in my 8th month of pregnancy. My mother-in-law was not at all ready to send me. I had to be stubborn about going. Only then did my mother-in-law send me here. This was a 17-year-old. I mean, can you imagine being 17 and trying to stand up? And many of our participants were so young. She had married at 15. Impeding access to hospital delivery. It's not a norm for a lot of the previous generation. They don't understand why you need it. It's additional expense. Why would they support that? Thank God I was here at the health center with her natal mother at the time of delivery. Otherwise, they, her in-laws, would not have allowed me to deliver the baby at the hospital. They delivered all the children of my elder Pabi, which is sister-in-law, at home only, and they didn't go to hospital for delivery. She was 20. She was married at 18. Neglected or ignored at delivery. My parents live in a village which is nearby my in-laws' village, so at the 2nd month of my pregnancy, I went to my parents' house for the delivery. But as I delivered a girl child, no one from my in-laws' house came to see me or take me home. She was married at 16. She was 22. In the postpartum period, again, you still see the issues of impeded access to medical care, eviction. I'm not going to read those quotes because it's getting long, but I did want to share one more, which was postpartum control over fertility and childbearing. Often they, my in-laws, want a boy child, and as you know, I delivered a girl child. Of note, this participant already had one boy child. My sister-in-law has some uterus problems, so she is unable to conceive a child. Now my in-laws want me to deliver another child, become pregnant for another boy, and give the girl, her new infant, to her sister-in-law. Nobody's even asking me. They decided on their own. I feel very bad about it. These are my own kids. I don't have any right to make that decision. She's 17. She married at 15. So you can see that these, and this is why I did the presentation called Intersecting Issues of Gender-Based Violence and Disparity, because you can see that they're all coming together. Son preference and you know, domestic violence from in-laws, from husbands, the early marriage of girls. So this one, I'm going to actually, if you ask me about these analyses, I'm going to ask Dr. Coker to explain them to you because I did not do this set of analyses. I was actually, I was not the first author on this paper. Dr. J. Silverman was, and this is just a level of analytic capacity that's beyond me because the outcome was based on the mortality rate per 1,000 births. But what I think is really important is that, do you guys know how to read odds ratios? No? Okay, all right. Just trust me, okay? That's what all statisticians say, right? Okay, so here's the bottom line. If you look at the last column, if you see a 1.0, if you see inclusion of a 1.0, that means it's not significant. So what you'll see is, for infant mortality, it's 1.1 to 1.2 for the female here and the female here. This means that there is an increased odds of mortality for the girl child, and more importantly, and not the boy child. We don't know a physiologic reason that can explain this phenomenon. But then when you hear those quotes, you kind of think maybe we know of a sociologic or psychological reason for it. One of the things we also, I think it's going to be coming out soon, is a paper on birth of a child and breastfeeding, and because basically what happens is if you have limitations in the nutritional resources, there's actually been a demonstration of prioritizing the girl child over the boy child for food, but also prioritizing the breastfeeding mother more if there's been a boy child that's being nursed. So what are the big conclusions here? Marital violence does not occur in a vacuum. It's reinforced by multiple forms of violence and oppression of women and girls. These include early enforced marriage of girls, abuse from in-laws, and son preference. Of course, this occurs at the individual level, but it's occurring at the societal level too. It is not simply that a girl in a family is going to now, because of the nature of that family, have this happen. It's supported by larger community norms and by just and it's that much worse in a context, I think this is the next slide, it's that much worse in the context of inadequate resources for the family. So if I have this much food, I mean physically, if I literally have this much food, who's going to get prioritized for that food? Those people who have greater value. If I value my women and girls less, why do I feed them as much? And so yes, the point is that this is directly tied to the lower status and value of women and girls in society relative to that of boys and men. And that's why you cannot simply address things at the individual level. We have to be, and this is one of the struggles is that largely a lot of what we've done, we've really tried to focus on these women. These women had the power, I think they would have changed in the first place. This is not to take it away from them, because I think that those are important solutions. Because guess what, if I work on him and this is not what she wants, I didn't do her any favors. So I definitely believe those approaches are necessary, but we have to be reaching men, community, institutions, and society, which society means policy and social structures. You know, there are laws in place. There's been a law since 1929, I think, in India against child marriage. Their law was a little low on the age. It was 12, but the point is that they put the age in. And by 1972-73, the law was 18. 45% of 20 to 24-year-olds are married prior to that age. And this was data from the mid-90s. We have a problem, obviously, or data collected from the mid-90s. We obviously have a problem. Policies are not sufficient. Social structures are vitally necessary. So for example, a lot of things what we're trying to think about is there's microfinance programs. I'll tell you, if we have time, the issue with some of those things, because it's not always easy to be able to have these when women in the family don't have certain structures in place to allow them to use it. But you've got to be thinking beyond, hey, we'll give support services and give her a safety plan, which is vitally important immediately. But it's not a long-term solution. And we have to be thinking of more long-term solutions to reinforce and support her to make the changes in life that she chooses to make. Okay, so what does this mean for public health? Because ultimately, I'm out of public health. And so we know, again, from some of the people in this room, that IPV has an impact on maternal and child health, reproductive health, injury, mental health, a variety of health concerns. And certainly we understand that abuse and abuse-related stress in the perinatal period is particularly risky. But also there is the issue of early marriage of girls. So in the context of India, what's happening is that there's been enormous strides. I showed you that fertility rate is not a high fertility rate. In Afghanistan, it's 7.7. I mean, it's not a high fertility rate in the context of the world. Here's the problem. In India, the population control efforts have been it's been really rooted in doing sterilization. So they incentivize sterilization. So you get married at 15, you have the kids you want, and then you get sterilized. And maybe that's going to be at 22, although we actually found in one of our studies that they're sterilizing minors, which is not supposed to happen. But even if they're not, let's say okay, we're not going to sterilize minors. Well, she's 15. I don't know that you're doing her a favor. Or she was 13 when she got married. I don't know that you're doing her a favor if the only option she has is to wait till she's 18. This is a very complex and controversial and ethical issues. But the bottom line is, if you have someone marrying at this age, and there is absolutely no contraceptive use until this age, at which point sterilization occurs, you have a long period of childbearing. What does that mean? These are the health effects of adolescent pregnancy and childbirth. You have maternal mortality rates that are higher. You have delivery and pregnancy complications that are worse. We actually have not found this to be true in India, although it does show to be true in high prevalence countries within Africa, but HIV risk is greater. You have worse situations of infant and child morbidity and mortality. One of our studies found that the early marriage, we saw a difference in the growth of the child. There seemed to have been a nutritional deficit for these children. One of the reasons we think is the case is because if I'm 15 and I'm pregnant, my body doesn't know, like, okay, I'm supposed to grow the baby, but I'm supposed to grow this person. And that's not just an India issue. I mean, we have this in the US as well. We have a ridiculous adolescent pregnancy rate for a country that's this kind of wild. So we need to be thinking about all these issues. And so this is a framework that I've been thinking a lot about based on the research we've been doing, is that so if we want to affect these issues of maternal mortality, and in maternal mortality I include in that these issues of HIV and STI and related morbidities that can lead to increased risk for mortality, and infant child morbidity and mortalities. Just disregard the culture. I didn't do the thing right. Just give me a minute. We have to affect their sexual and reproductive health. We need to actually improve the situation in terms of unwanted low-space pregnancies, pregnancy and delivery complications. How do we do that? We need to improve healthcare acquisition, and we need to alter behaviors in terms of early sexual activity and contraceptive use. In the context of India, adolescent pregnancy is a marital phenomenon. It's not, so which is not to say that if you took away that there would not be adolescent sexual activity. I think there might be. I mean, I understand that there's biological urges, but it definitely has impact to have early sex, and how early and in what context is vitally important to consider. So what leads to that? Well, certainly there's these behavioral mediators, knowledge, attitudes, knowledge, risk perceptions, self-efficacy, which means do I feel I have the capacity to alter the situation and make it into what I want. But also this issue of traditional gender role ideologies. One of the things that's really reinforcing a lot of this is that I put male, but it really is both. It's both male and female. It's the idea of what girls are to do in a relationship, what women are expected to be in the context of families versus males and boys. And certainly these things are happening in a context of vulnerability. So in a context of, and this is a global perspective, in a context of where you see a lower human development index, we're in a context where issues of mobility and access to care are at play, in higher levels of poverty, unemployment, residential instability. That's actually a US phenomenon as well. We're doing a study right now. If you look at black communities, these issues of unemployment, homelessness directly tie to all these concerns as well. But here's the thing. We have to think about gender as part of this. We have to think about gender-based inequities in the actual economic positioning of women and girls in our society. We have to think about the violence they face to maintain those inequities. We have to think about the disparities in terms of the family placement. And I say marriage, but also domestic responsibilities. I mean, what is expected of you in the home? This is unpaid labor. And when you take unpaid labor and make it unevenly distributed, you now say you were worth paying and you were not worth paying. Oh, and by the way, you're the woman and you're the man. Wait, did I get that right? You're the woman and you're the man. So, and all of this is reinforced by culture, certainly. And you have to be careful because you don't want to change culture. But one of the things we say is, like, all cultures, all religions have those things that can be used to reinforce things that are not healthy, but they could equally be done to reinforce things that are healthy. And so that, I think, is where we need to start. So for example, we were doing stuff with Afghan religious leaders, and so the question was, well, when a girl is an adult, then she can marry, and that's been based on menstruation. Well, okay, menstruation is one aspect of physical development, but pelvic growth is another. Should we also be considering that? Because it never actually specifies menstruation in the Quran. So these are the dialogues we could be having that can be more respectful and engaging of people. So what can we do?